Good morning. Assalamu alaikum. So since morning we have been, or since last few days, we've been talking about trauma, global neurosurgery, and that is, I think, the need of the hour. But my interest is in neuro-oncology. So I am a sort of a newcomer into the global health aspects, from the angle of oncology. And that's where my interest lies, and that's why I want to talk about that repeatedly. So this is not unusual to have cases like these where a middle-aged man or late middle-aged man who does not have much resources has a GBM, which you can pretty much say without biopsy, and doesn't have enough resources to really go through the treatment. And if you put them on that track, you may be able to do something maybe in the hospital, like through welfare or through other systems. But then for chemotherapy, for radiation therapy, he will be going from pillar to post, and eventually all the family will be on the street because he has lost. This gentleman himself had about 1.2 million rupees total assets, and he would have been total destitute coming from the up north region. So I told this to his son, who was the earning person, and I said, "Look, your father will live for maybe 9 more months if we do everything, but then it will really push your family through a lot of stress." So he understood that. They took him back and gave palliative care. Or about this patient who had a low-grade glioma resected, but didn't follow up for a few years because finances issue and distance issues, and an MRI is expensive, and came back after repeated seizures with a big recurrence after a few years. Couldn't monitor this patient. So I know all the people over here are expert of this thing, but just to revise that, how we should understand that the low middle income country, that's a big population over here, and then 50% people live under $2.50 a day. This is an old data, but still it shows that about 10% live in less than $1 a day. And when we look at the population, India is actually going to probably go beyond China, become number one in a couple of years, in a few years. We are on the way to beating Brazil, Pakistan. So we are very proud of those achievements. Uh, but we fail to understand that in the wake of all this population growth, what's happening. So the global surgery, and I think again a lot of people have talked about it. Lancet Commission came out and all the things. Just to remind you a few things, these numbers are probably everybody remembers that the 5 billion world's population is without access to safe and surgery. $21 trillion is lost in global productivity, and it only requires $350 billion overall as an assessment to fix that. If you look at the surgical diseases compared to HIV, TB, and malaria, surgical diseases which can be treated and improved is just tremendously high. We tend to ignore that. And by the modeling analysis, if you look at the access to the surgeon, to the surgical care, we really are in a very poor condition over here. This is Pakistan over here, and in this data, by that and that in that modeling study, if you look at it, we are about 99%. Congratulations. So not only in population we are at getting there at the top, we are pretty much close to 100% in our proportion with no access to surgery. So this is just these words by John Mira at Brigham and Women. It always, whenever I read it, it just gives me a very strange feeling. I will just read that. For many, it is simply a lack of money. For others, it is the tyranny of distance and poor transportation infrastructure. For the remainder who can afford it and can travel the distance, they arrive to find a feeble healthcare system with too few surgeons or anesthetists, no medications, no oxygen, and no blood for needed transfusion. an era in which we discuss the dawn of personalized medicine and genetic engineering with frequency and familiarity, how can we allow more than half of the world's population to live in a healthcare time warp, trapping them centuries in the past? Uh, so the standards that have been set up by the Lancet Commission are here: 80% access to timely essential surgery. The surgical volume has to increase to more than 5,000 per 100,000. Less than 20% should be at the risk of impoverishing expenditures. The risk of catastrophe expenditure should be less than 20%, and more than 20 per 100,000 specialist surgical surgeons and specialists. I will talk more about in the next talk in the afternoon on these things. What is the problem in Pakistan? In Pakistan, the problem is one is distance. So this is Aga Khan over here, and the distance from here to here by air is about 1,300 to 1,400 kilometers, and this is the overall population that arrives at AKU for brain tumor surgery. Now, we are not the only center. There are excellent centers over here in Lahore and in Faisalabad and Islamabad and Pindi, and I'm sure they are also flying from distant beyond the country into those regions. This just gives an example that the amount of distance that they have to follow. So you can imagine how would they follow up every 3 months or every 6 months if they're flying this much of a distance. And that's a problem that we have in low-income countries, uh, distance problem. Middle-income countries, only the high-income countries have a better setup on that one. And then obviously the public versus private sector institutions, we are all aware of that. And I'm not saying that all public sector institutions are in poor condition, and I'm not saying that all the private sector are in better condition. It can be other way around, but overall, this is generally a problem that we see. And then surgery for those who cannot afford. So look at the amount of money that is put in health over here. This is an old budget, but hasn't changed significantly. The population with insurance in Pakistan is 1 to 2%. That's all that we have. More than 20% below poverty line. And the cost of craniotomy in Pakistan is about $300 to $6,000. And the GNI per capita is less than $6,000. So how do we deal with it? We have philanthropy all over Pakistan, and this is welfare from AKU, and we have put in about $22 million in 2018 for healthcare. Then Shaukat Khanam, we all know our Prime Minister's institution. Then this is Indus Hospital, where there is no cash. You just walk in, get the treatment, get out. You don't have to give a single penny. But then, these are all private institutions. It can't take the burden of the country. Uh, if you look at the low-income countries and the lower middle-income countries, the catastrophe expenditure, all quintiles from the rich to the poor can be affected by the catastrophe expenditure. What is catastrophe expenditure? Enough expense on healthcare that pushes you below the poverty line. 44 million households face catastrophe expenditure every year, and about 25 million households every year go below the poverty line. So the reason for that in Pakistan is out-of-pocket payments, low household capacity to pay, and lack of prepayments mechanism, no insurance. Of all the diseases that we see, cancer seems to be at the top because the blue one is the cancer. This is the catastrophe expense. If you look at this is cancer, this is injury. So although we're focusing a lot on trauma, which is right, but cancer is also a major player in here. And if you look at it in terms of distress financing, so blue is distress financing for all diseases, diabetes, asthma, diarrhea, and all that stuff. The cancer has the highest distress financing over here. Cancer is highest in this part of the world, about 50%. And that is confounded by this, that the new patient consult per year per oncologist is highest in low middle income countries. So each oncologist has to see many, many more patients in here. And we, again, congratulations, we are at the top over here also. So Pakistan has the highest number of patients coming to the oncologist compared to the global median over here. Although a lot of things have improved globally in terms of cancer, the survival, but the survival of breast, prostate, colorectal, and all those cancers is still high in the low middle income countries than in the high income countries. And cancer from brain is doing much worse than leukemia and other things. So cancer kills more people in low and middle income countries than HIV, AIDS, tuberculosis, and malaria combined. 80% of global cancer deaths occur in LMICs, but only 5% total global spending on cancer care is expended in these regions. And that's why my interest, I have coined this term and I have asked for permission and apologies to my mentor, Dr. Tariq Khan, that global neuro-oncology is a term that doesn't offend you at all, right? Okay, he says yes. Okay, thank you. So, so global neuro-oncology is what I focus on. So how do we fix these things? So we talked about in the past, build a consortium. There are about 40, 50 hospitals in Pakistan, and that can be done. Build a registry. I'm working on that one now. I'm working on the Pakistan Society of Neuro-Oncology. The paperwork is almost done. Based on this, we will start on this thing. And then standardized tumor board all across the country. Those are some quick fixes that one can do within a couple of years. Telemedicine, a submitted grant to uh, Belinda Gates Foundation. We do have a telemedicine system in AKU. We want to improve on that one. But then if we get some more grant, we can set this up, and that can take care of all those long distance patients. We can set things up with them. And it has shown effect in other part of the world. That was in Kenya, for example. And then research on liquid biopsy. So that may be a little esoteric stuff, but I think it will reveal results. Doing an MRI every 3 months is very expensive. Liquid biopsy eventually should be the answer for that, either in the serum or blood, not in the CSF. And there is data that has shown that you can see recurrence versus no recurrence as positive in liquid biopsy. So looking at the non-coding RNA that we are working on at AKU, I don't know if we will get any results or not, but that's something we should do research-wise. AI, mentioned earlier also, where we don't have to train excellent neuroradiologists all over the country, but using the AI, we can set this up. I have come across so many cases where a simple GBM or metastasis has been called a TB, and the patient was on anti-TB tuberculosis medicine for about 3 months or 6 months. This is TB. This is atypical meningioma, GBM. This was an abscess, and to an unexperienced person, it may look same. And we don't need to spend money in these things. Gliadel, $12,000. Total craniotomy is $300 to $6,000. $12,000. $1,100 for ALA, 5 ALA. We got this stuff. We got this stuff, and I don't feel proud of it. The whole robotic system, nonsense. Well, I shouldn't say that. Please scratch that if it's a video recorded, because my company will. Okay, all right. And then navigation system, maybe in some places, high-end microscope. Forget the MRI, intraop MRI. Forget that. So what you need to do, you need to train a group of surgeons who can fix things without these high tech. We need to do only essential technology. And here's an example that I showed earlier also, that's something close to this. I did not need a DTI, just simple subcortical mapping, and one can achieve an excellent result. And how many of you have really done a cervical laminotomy with the Hutzel brace? Has anybody done that? My mentor, thank you, Dr. Shah. My mentor, Dr. Gauss Malik in Henry Ford, taught me to do that. He said, you will go back to Pakistan, you need to know that also. You can do a cervical laminotomy with a Hutzel brace. But so we need to train people for that. And not only train those techniques, but we need to train some individuals as local leaders into clinician researchers who can look at this stuff. And this is the long-term goal. Maybe 5 to 10 years, we should be able to come up with a group of neuro-oncologists who can understand the context, understand the landscape of Pakistan in neuro-oncology and fix things. And we have talked about, all the speakers have talked about this thing. We can't put a square peg in a round hole. So the NCCN guidelines should be modified, and it has been modified by in some cases, and it has worked very well. So we need to come together, modify those guidelines, which are pertinent to over here. Gliadel should be scratched out. The follow-up should be limited. I mean, there are a lot of things can be done. So that needs to be worked on. So basically, there are a lot of steps, a lot of things that need to be done. And it's, again, a cliche kind of a thing. a thousand battles and a thousand victories only happen if you know thyself and you know thy enemy. Thank you very much.